All right, thank you all for the opportunity to present a topic that I'm passionate about. I've been a pharmacist for almost 25 years at this point. And early on in my career, unfortunately, I learned about drug diversion by the fact that I was working with a colleague who unfortunately had some home life stressors. And then as time went on, I realized that she had just not been around at work. Um, Unfortunately, she had been borrowing some of the medications from the pharmacy's controlled substance safe, and she, was gone for a while. When she came back to work, fortunately, she was able to, maintain her license, come back to work without access to controlled substances for quite a long period of time. The environment that she came back to work in was obviously a lot different. And so early in my career, I had that experience. And then I would say over the last 25 years, I've had the opportunity to sit in front of people that we're talking with about drug diversion prevention, talk with people who are actually being investigated. And each time at the end of it, I see an individual who's suffering, who we heard a lot about burnout yesterday. I've seen clinicians just roll up their sleeves and say, thank you, I have a problem. Having track marks, I've seen clinicians, unfortunately, we've all seen the stories. And so since I've switched from clinical practice to the vendor side, I'm now in medical affairs with BD. I'm excited to be able to talk today with one of my great partners, Dom Carollo, about our partnership as it relates to drug diversion prevention in his hospital system. But this is something that I'm passionate about. And I'm excited to say that that pharmacist that I was talking about earlier has been in sobriety now for 25 years. She is great in recovery. And now she's my sister-in-law. So I didn't know. I ended up meeting him a couple years later. So I've been alongside a family member in recovery. I'm sure many of you likewise have people in recovery. And so for me, this is not about catching the diverters. And you may say as a pharmacist, that's odd because your job is to be the police of the narcotics, right? But for me, it's personal. And so I come at it with that passion and belief in recovery. And so we need to help detect things sooner rather than later. So today we're going to talk a little bit about the problem of drug diversion and the challenges associated with it. But we're also going to talk about how technology has evolved. I started back in pharmacy practice in the 90s. So paper orders and all of those wonderful things that were so challenging to be able to triangulate where you might have challenges. We'll talk a little bit about that. We'll talk about the role of an IT partnership, really focusing on that vendor to clinician partnership, and then share kind of what a vision for the future may look like. So the current state, maybe just show of hands. How many of you have worked alongside a colleague or peer that has struggled with substance use disorder? Almost every hand went up for those of you who are virtual. Leadership really, a couple of years ago, BD did a study to look at how many people really thought that there was a problem with drug diversion prevention in their hospital. And everyone said, yes, I understand that that's a problem, but it's not going to happen to me. Not in my hospital, not in my health system. And over the last several years, we've really seen a shift in that. Unfortunately, pharmacies and health systems have seen massive fines related to DEA investigations due to drug diversion cases. And so there has been a little bit of a shift. And with that, there's also been some new guidelines that have been developed. And then the role of technology has really dramatically changed over the last 10 years as it relates to how you can go about looking at these things and hopefully detecting it sooner so that you can get that clinician help. The headlines are not favorable, particularly around anesthesiology and the practice of anesthesia. And these are just 4 examples. I've redacted the names, but at the end of the day, the stories are horrible. These often, when they happen, hit headline news. And nobody wants your organization or your close colleague to be in this situation where their name's in print, or further, that they might actually be deceased. The ripple effects that it has on healthcare, the team that's remaining when this kind of thing happens is really devastating. And so we want to prevent this type of thing from happening. And unfortunately, it's really not just about the clinician. And, obviously, we first and foremost want to get them the help they need, but it's about the patients. And drug diversion is a patient safety problem. And I have to applaud so many organizations coming out and really thinking of it in that lens versus just the compliance lens over the past few years. ISMP has been a strong advocate for this. American Society of Health System Pharmacists has as well. But really, at the end of the day, when you have a clinician who's impaired, there's a patient who's either not getting the medication that they need so that they could still be in pain. They're getting underdosed or maybe not dosed at all because it's been tampered and substituted. Or worse, how many of you saw the podcast about patients who were having egg retrieval without pain medications? I mean, if you listen to that podcast, it's just heartbreaking to think about the pain that those women were in going through those procedures. And then there's the latent things like hepatitis that may not be detected for years. And there's been many, many cases like that. And then other bacterial infections. And I won't go through all of those, but there's also an active case in the Pacific Northwest where there's essentially 16 related tampering deaths where water was substituted for fentanyl in an organization. And there's up to 44 investigations that are continuing to ongo in that case. So this is a real problem. As you constrain the system, you have a lot more of these tampering cases that can have even worse and more really devastating consequences for the patients. So the American Society of Health System Pharmacy has developed some guidelines over the past few years, 2 versions of those. The first of being in 2016. I had the opportunity to participate in the 2022 guidelines that were updated. And I would say it was an exciting time to really think about what had changed from 2016 to 2022 as we rewrote these guidelines. One of the things I would say is that, 2022, we were in COVID still, we were really kind of coming out of it, but we recognized that a lot of things needed to change about these guidelines from the first draft to where we were at that point. And so I think the key call outs are that, it used to be a pharmacy problem. They really called on anesthesia leadership and the important role of an anesthesia leader on your drug diversion prevention program, and then it needed to be more multidisciplinary in nature. They also highlight, obviously the areas that are of greatest risk, and no surprise to this audience that the controlled substance volumes in the procedural spaces remain high risk for potential diversion, and you need to have a little extra leadership and attention and processes there, including automation and technology, things like automated dispensing cabinets, as well as having surveillance programs. And surveillance programs can look at a couple different things. I know many people have gone down the path of implementing cameras in the operating room that can specifically look at where your controlled substances are moving, obviously protecting the patient's privacy still. That's one aspect. But then on top of it, we have the robustness of new drug diversion prevention surveillance systems. So just a little bit more about advanced analytic technology and drug diversion surveillance systems. So when I was a early pharmacist in the 2000s, I remember the nice reports that I would get that would tell me that, this nurse or this physician or this pharmacist was an outlier versus their peers and a statistical deviation. And there were always so many reasons that wasn't the right way to look at it. Maybe it's that nurse for good reason was picking up extra shifts, or that that was the pain nurse for the floor that did those types of things. And there were patient, things that you would look at, obviously, but it was really difficult. You spent a lot of time looking at reports. You spent a lot of time trying to triangulate what you really needed to be spending your time on to make sure that you were helping that clinician. And now these advanced analytics really help you kind of triangulate people who really look different for things you can't see with the naked eye. These are often powered by artificial intelligence through machine learning algorithms that are really complicated. And I'm by no means an expert in any of that. But what I will say is that as a clinician, I was able to often see these types of things are maybe somebody that I need to look at a little closer. I don't think that most people rely on these as the perfect needle in the haystack to say that this person is diverting. I think most people are of the mindset that this helps me see where I need to spend my time and who I really do need to look at a little closer. And maybe let's have a conversation with that person sooner rather than later. But the types of transactions that these things include are like, I dispensed a medication after the patient was discharged. That's interesting. Why? Maybe that's a conversation. Just maybe they chose the wrong patient, or maybe they really are doing something that you need to take a closer look at. How long is it that you're from the time you remove a medication until you're wasting it? And then are you just not really good at documenting? Maybe we need to have a conversation about that again. And then what about things like I'm pulling out a vial and I'm always wasting the whole thing, which benign probably if you see it periodically, but if it becomes a pattern or trend, you might start to worry about potential for drug tampering. And then if you have a buddy system, we see that a lot in nursing where people may work together to consistently waste, and that is a recognized pattern of potential drug diversion. So with that, I'm actually going to turn it over to Dr. Carollo, who's going to talk about the experience at Ochsner.
Hey, y'all. Thanks for having me. Thank you, Dr. Rabella, and the rest of the committee for inviting us. So Ochsner is to say a large hospital system in the Gulf South is understating it. It's the #1 hospital system in the Gulf South. And saying that we do 46 hospitals and more than 370 health science centers, so many ORs I can't count. I asked my pharmacist, how many opiate and narcotic pulls were there in 2023? And the number was 3 million across the system. 3 million different dispensions across the entire system last year. All right, so here, this is not the most fun topic to talk about, but substance use disorder. We know that we represent, as anesthesiologists, 1 in 25 of the physicians across the country, but yet we represent about 1 in 9 of the physicians that are that have substance use disorder problems and are currently undergoing rehabilitation. It's considered our #1 hazard for our profession. And we know that 1 in 8 of us will develop substance use disorder, and 4 in 10 will relapse over the course of their career. And we know that if a resident were to get substance use disorder, 1 in 9 of them will die. In the last 4 years, I can tell you this, we've had 2 residents that we've had to help with substance use disorder, 1 from anesthesia drugs, and then 1 from what I would say, quote unquote, party drugs that we've been able to find through some of our diligence. All right, so I started residency in 2007, and looking out at this crew, I might be the youngest resident here. No, I'm just kidding. We documented on paper. Looking at Dr. Phillips, I'm sure that she documented on paper a long time, but we've all converted over to the electronic medical record, and that happened during my residency. Currently, of course, at Ochsner, we use Epic. And by the way, I'm sure a lot of people are going to use Epic. I am currently the chairman of the Epic Subspecialty Steering Board for Anesthesia. So if you have a lot of complaints about Epic Anesthesia, you can find me. My email is at the end, and I will try to help you out the best we can. But that was a huge transition that just happened even in my career. Storage, man, I miss the tackle boxes a little bit. Just go get the tackle box, you lock it in your cart. But we all know that the automated dispensing cabinets is safer, and and hopefully a lot of us have transitioned to that. And that has been a big change in our careers. Labeling systems. I sort of miss the labeling roles. I don't know what you guys did sometimes during a long case. We'd make artwork with them. You'd wrap it around your arm. You make bracelets. But then obviously when Jaco would come by, we'd all have our marker, and you'd have to write down, oh, DSC, the date it expired 24 hours from now. And then as soon as Jaco left, you'd throw that marker away. But we know that the codonics and those automated labeling systems is much safer for our patients and much more reliable of a system. So waste detection, we went from a system where during my paper record, my attending would come in, he or she would sign for attestation for emergence, for presence, for induction, and then they would sign the waste at the exact same time at the beginning of the case before I had given even most of the narcotics. That was just a signature on a piece of paper. Not saying that was a good, reliable system, but it's the truth of what it was. Now, of course, we have 2-witness authentication. For us particular, it's through Pyxis, but automatic dispensing cabinets, or some people can do it within Epic. And then, of course, the surveillance software. So as a lot of my colleagues here were talking about with the dashboards, we have we have data that comes out of the automatic dispensing cabinets. We have data that comes out of Epic. We have data coming from everywhere. And we have they would send an email to the pharmacist would send the email to a chairman, say, hey, this looks funny. Or one of our people would send an email to the chairman and say, hey, you need to look at this person. And then they would take a long time to be able to do those deep dives. All right. So today we're going to talk a little bit about that transition. All right. So Ochsner, different sites, different places. We got to go from Shreveport, Louisiana, which is a 6-hour drive, down to New Orleans, and they still were using a manual system in Lafayette, and we're using automatic dispensive cabinets, of course. Epic is ubiquitous everywhere. In 2019, we failed an audit, a DEA, a DEA mimicking internal audit. And of course, a personal friend of mine was in charge of the audit. And then she recommended to my chairman as a favor to me to be the anesthesiologist that would be in charge of reconciling all the audit findings. And I always appreciate Angel for that. So the first thing that we did, and this was through collaboration with the pharmacy and a great pharmacy leader, is that they hired someone named Alex. Now, Alex already was working in pharmacy, but he became the system-wide drug diversion, I'm going to say czar, but drug diversion director for the entire system. So we have one person for pharmacy, and he has 4 or 5 reports underneath him that is really in charge of making sure we can be reproduced across the entire system within Ochsner. Once again, 46 different locations. We have an internal manual process at my hospital, and we wanted to be able to reproduce that across the other hospitals. But the problem is the 2 people that do that, I'm going to give you their names. Their names are Lisa and Sandy, can't be just replicated and spliced and put at these other hospitals. And they can't do the work of all 3 million of these pools either. So how do we do that? And so we realized that we need to develop the IT. So of course, once again, all stories happen, during COVID. But then once we were coming out of COVID, we had identified a partner, and this partner particularly was BD, but it could be any of the vendors that was really interested in developing this analytics software on the back end. And we had meetings every Friday. They were looking at our workflows, looking at my workflow, CRNA workflow, looking at resident workflows, and then also looking at on the back end, the actual the pharmacist workflows, what reports they were looking at, what spy tools that they were using. And we developed this software together. And then we just said, well, let's do it now. Let's implement it and see if it actually does anything. So this is the study that we published in 2024. We finished this research in 2022. And really, I'm not going to go through all the details of this. Feel free to read the paper. But long story short, it just reviewed, the software was designed to review all the OR transactions and to try to make it, and to also review all the dispensions from the automatic cabinets and to try to correlate them together to see which actual discrepancies were real and which were sort of false discrepancies. And then also, what were the weird sort of things that could lead to someone to be able to be diverting. So as you can imagine, we found a lot of charting anomalies, but the 2 that I want to point out most, and 2 that we were not looking at before, was the whole dose waste or return. We did not find that to be as common in our manual process, but as you can see, there were almost 27% of our total discrepancies were found to be this whole waste return post-implementation. So some report was finding that, and yet it wasn't getting back to the anesthesia team that this was actually happening. And then the other one I want to talk about is dispense after discharge or transfer. Our initial reports weren't finding that at all. And that's a very easy diversion technique. Oh, the patient went home, let me go pull some fentanyl from them. And this new software and this new analytic tool was finding that. Obviously, the analytics save time. We went from 3 days to do a review of a particular provider down to under an hour. And we can do those reviews, and then a pharmacist will do those reviews. That gentleman, Alex, will see the abnormalities, and then he will call the chairman or call me, and we'll do a secondary review of looking at their cases. And sometimes we've had to actually go through and do drug tests, random drug screens, to make sure or to be able to help. Because remember, as people said, as Amanda said, we're trying here to help people and to save lives. All right. So the vision for the future. Obviously, we all have the two signature, however you all do it within Epic or within Pyxis. But what is in that syringe? Is it fentanyl? Is it that the right amount? When you actually squirt it into the terminal waste, is that the right drug that you're doing? Do you know that it's saline? Now, we know that there's technology out there that's trying to look at like mass spectroscopy to like say, oh, that's fentanyl. That actually is fentanyl. And it's really clunky. But the goal, help long term, is that we will have this technology that will really be able to use to know what's in that syringe and know what volume is in that syringe. But none of that is ever going to overcome us being a culture of safety. We had very big tragedy a couple weeks ago. We had an anesthesiologist pass away from overdose, and he had 0 Pyxis pools, 0 wastes. Never, he was doing a direction practice. He's a regional anesthesiologist. Well, he was reaching into the waste bins and taking out the old 2 ml vials, and he had 50 of them in his hotel room when he died. And obviously, in hindsight, the cameras did catch him, but not beforehand. It's because no one was looking at that, because he had no warning signs. None at all. None that I personally could see. And when you ask the people that knew him the best. So the technology is never going to get us all the way there, because diverters are going to divert. But I want to be really clear is that we can work together, and we can be vigilant for our colleagues and our friends, so those type of things do not have to happen. But no technology is ever going to be better than us being vigilant. All right. Thank you all very much for inviting me.